Hey everybody, we are ready to start Farm 3. I was so glad to hear everyone was safe. I know my own family, it took a while for us to get to some cell signal to let everyone know, but I am so happy everyone is safe and sound, and I can't wait to see you all in person again. So when we're starting Farm 3 here, we're going to start off with thyroid medications for both hypo and hyperthyroid, do a brief overview of our steroids that we've talked about in all of our other quarters for pharmacology, and then also we're going to start off with some of our diabetes medications. If you need anything during this time, everything's kind of thrown for a loop right now, certainly reach out to me. I'm sorry if anyone was severely affected by the storm, lost any uh, property or things or loved ones, so certainly reach out to me if you need anything at all. Let's start with a brief just overview, review of the thyroid gland itself and the hormones that we're going to be talking about a lot with these medications. So the thyroid gland of it in and of itself is going to be producing two main hormones that are utilized with our body functions. The first one, that's one of our active hormones, is our T3, which is our triiodothyronine. This one is going to be our most active form of the thyroid hormones, which is going to play most of the roles in regulating all of our physiological processes that we talk about with thyroid hormones. The second one we see is our T4, or our thyroxine. This is going to be our most abundant form. So even though our most active form that does most of our regulation is our T3, T4 is what's most abundant within the body and what's produced the most by the thyroid gland itself. Its main function, though, is really as just a precursor for that active T3 form. So most of the effects, again, associated with a thyroid hormone are going to be mediated by that T3, and T4 is mainly just acting as a source for that T3. T4 gets converted to T3. T4 has the most abundant amount in the body, but it's just acting as a source as it gets converted to T3. And then what are these actions that we're talking about that T3 is really doing, since T3s are a more active form? And these are used to help stimulate energy use and regulating our metabolism and energy balance in the body. It can stimulate the heart, helping increase our heart rate and cardiac output. And then they're also really involved in growth and development, which is going to be really important in early life, as far as like brain development and overall growth in children. The thyroid hormones act in a feedback loop similar to some of the other hormones that we've talked about throughout the body. The regulation of these production involves a number of steps, similar to when we talked about steroids. It goes through multiple different parts of the body before it gets to its biologic effect, and then depending on the amount that's there, it sends a negative feedback to either stop production, or if there's not enough, start production. So we're going to first start with the hypothalamus, and then it moves through the pituitary gland before it actually gets to the thyroid itself. The first thing that happens is thyroid releasing hormone, or that TRH, is going to be released from the hypothalamus. The TRH is then going to stimulate the pituitary gland to release then TSH, or thyroid stimulating hormone. Once the TSH is released from the anterior pituitary gland, it acts directly on the thyroid gland. And then the thyroid gland is then going to release those two key hormones that we talked about on the last slide, your T3 and your T4. So again, T4 is our thyroxine, and it's going to be the main hormone secreted, and it's acting mostly as just a source of our most active form, T3, or triiodothyronine. And this conversion of T4 to T3 is going to be mostly happening out in the periphery of the body, not necessarily in the thyroid gland. And if you have enough of your T3 and T4, you're going to have that feedback back to the anterior pituitary saying, don't send TSH to the thyroid to create more because we have enough right now. Or if the numbers start dwindling, then that feedback loop goes to the pituitary and the hypothalamus and says, okay, we do need to release more. Let's get the production ramped up again. So now that we know just the overall loop of the production of the thyroid hormones, let's narrow it into the thyroid gland itself, looking at how then does T3 and T4 get created. So this production is going to start with active transport of iodide. And once that iodide gets into the thyroid gland, it's going to be oxidized by peroxidase, which is an enzyme. Remember, anything ending in ase, we're going to think it's an enzyme. And enzymes are going to transform or convert things. So it's going to take that iodide and it's going to convert it into its active form, iodine. That iodine is then going to incorporate with tyrosine and the thyroglobulin. And this is going to form two distinct molecules. When tyrosine binds to one iodine atom, it's going to become monoiodotyrosine, or the MIT. When it binds to two atoms, it's going to become diiodotyrosine, or our DIT. So when this happens, when we're looking at how does it become T3 or T4, it depends on how many of those MIT or DITs you have. So if you hear my little ones in the background, I'm sorry. So these iodinated tyrosine molecules are going to couple. And that's going to be how we decide if we have a T3 or T4. So if we have one DIT and one MIT, you're going to get a T3. Versus if two DITs come together, then you'll get a T4. This is just to give you just a brief overview of what is the difference between those T3 and T4s and how does this happen within the thyroid gland itself. So this is just really trying to put the last few slides into picture form for you. If you're a picture form type of person that you need to see where this is all happening, this is your slide for you. This also shows you that out in the periphery is where you get that conversion of your T4 converting to T3. So they're both created within the thyroid gland and then get excreted out into the body. And then in the periphery, that T4 is what gets converted to T3, and the T3 is then in its active form. You can also see on that bottom right, it shows you some different symbols on where some of our medications that we're going to be talking about are working as well. So where our methimazole, our PTU, our beta blockers, where they're going to be working within this whole process to block the production of the thyroid hormones for our hyperthyroid patients. This is just another kind of picture form slide in order to go over with you as far as when you're looking at your lab work, because even though we are pharmacology, you need to be able to look at your lab work before and after you've started medications to know how these are working. So when we're looking at our lab work for thyroid function, we're looking at our TSH, which is going to be stimulating more production of our thyroid hormone. So that's why if someone is hypothyroid, meaning that they've got that low T4 or low T3, they've got low thyroid hormone, that's going to go through that feedback mechanism and you're going to have higher TSH because the body is like, I need more thyroid hormone. So hypothyroidism, the body has more TSH trying to stimulate the production of more thyroid hormone because those levels are low. Compared to hyperthyroidism, your hormones themselves, your T4, T3, are going to be high. Uh, and if those are high, it goes through that feedback mechanism and says we've got too much. So the TSH will be low because you don't want that stimulation of the production of more hormones. So these are just a couple different picture forms to look at that. And you'll need to be able to recognize your lab work when you're both before to be able to figure out what kind of thyroid disorder they have going on, and then after they start their thyroid medications, whether it be hyper or hypo, to make sure that they're getting to more of that euthyroid type level. They're not going too far in the opposite direction. These are just kind of organizing out in a picture form here, just the different types of medications we're going to be talking about in terms of our hypothyroid as well as our hyperthyroid. And we're going to start off with our hyperthyroid medications. So before we can get into our medications to treat it, let's just go over a little bit on how these patients are going to be presenting. If someone has hyperthyroid, they're going to have normal or high T4 with a high T3 level. Our high T3 level is what's leading to these symptoms. Because if you remember a few slides ago, we talked about how T3 is our active form of the thyroid hormone. So with that excessive level, that's what you're getting these symptoms from. You can get this nervousness, anxiety, emotional lability going up and down in your emotions because that thyroid hormone is going to be stimulating the sympathetic nervous system, causing kind of a heightened emotional response. We also talked about how the thyroid hormones can have an effect on the heart. They're going to increase heart rate. And with that stimulation, it has this kind of sensitivity to adrenaline and it can lead to palpitations. Your body can get fatigue. You're constantly being stimulated and it can lead to an overdrive and you get an exhaustion despite that increased energy production. And that's what's going to lead to some fatigue in your patients. Patients can get menstrual disturbances. It's going to disrupt some of that hormone balance with the menstrual cycle, so you can get irregular menstrual cycles. Elevated metabolism within the body because of that stimulation of those increased energy levels is going to also then lead to a raise in body temperature, and patients can become heat intolerant and sensitive to heat. Again, that stimulation of energy and metabolism can lead to weight loss and an increased appetite. So even with that increased appetite, because again, that faster metabolism, that stimulation of energy, these patients can get weight loss. And then again, stimulation of everything. Hyperthyroid, you're stimulating so many things. So you can get increased intestinal motility and hyperactivity of that digestive system, which is going to lead to diarrhea. When we start to treat our hyperthyroid patients, what are we looking for? What is our aim when we're treating these patients? So some of our outcomes we're looking for is to eliminate that excess thyroid hormone production. We want to try and normalize the function, get them to a more euthyroid state, achieve that chemical euthyroidism, so our normal thyroid levels. And then with doing that, our hopes is that we minimize the symptoms we just talked about and prevent any long-term complications like heart disease or osteoporosis due to the excess stimulation in the body. We're going to always, just like every other thing, individualize our therapy based on a few things. Sometimes we will base it on age or gender. Especially with our older adults, we tend to be more conservative, just like a lot of our other medical conditions that we've talked about in pharmacology. We want to be more conservative in our older adults. We need to consider if someone has heart disease, if they're pregnant. Have they had this before and something was either ineffective or caused side effects? Or did it just work really great? So we can take that into consideration too. These are just our different classes of medications we're going to talk about over our next few slides here. Now on to our medications. We're going to start off with our thionamides. Our main thionamide we're going to talk about is methimazole, which you're also going to see abbreviated to MMI. Methimazole is going to be our first line treatment for hyperthyroidism because it's going to be safer, more convenient, and it works faster than our other option we'll talk about, like PTU. However, you do have to keep in mind that it does take a while to get your patient to a euthyroid state. So it's going to take about 3 to 8 weeks to achieve that chemical euthyroidism that we talked about as one of our main objectives in treating hyperthyroidism. The mechanism on how this is working, if we think back to the couple slides ago, the production involves a conversion with peroxidase, one of our enzymes. How MMI is going to work is it's going to inhibit that enzyme. So thyroid peroxidase is an essential enzyme for coupling of the MIT and DIT to form T3 and T4. If that MIT and DIT can't couple together, then they can't create our hormones T3 and T4. So MMI or methimazole is blocking that thyroid peroxidase enzyme so you can't actively create your thyroid hormone. Our problem with hyperthyroidism is an excess thyroid hormone, so this is blocking further production of that thyroid hormone. We're using methimazole in a few different capacities. It's going to be commonly used for our Graves' disease. We might use it in combination or adjunct to radiation therapy. You might use it to suppress hormone synthesis before someone gets a thyroidectomy or has thyroid surgery. And then it might also be used in that life-threatening hyperthyroid emergency of thyrotoxicosis or a thyroid storm. What are our side effects or adverse effects that we have to watch out for with methimazole or MMI? We'll see a lot of these are very similar to PTU, our other thionamide, in the next couple slides here, but there are going to be a few key differences. One of the most concerning side effects that we have to worry about is agranulocytosis. This we've talked about a little bit on other medications, but just to remind you, it's a rare, it doesn't happen often, but it is a serious life-threatening emergency if it does happen, and it is characterized by an extremely low number of white blood cells. So your white blood cells are dropping to like 2,000. With that, you can significantly increase the risk of an infection in a person because they don't have those white blood cells to battle or protect against infections within the body. If someone is going to get this side effect, for the most part, it usually occurs within the first 3 months of treatment, and it is going to be considered a medical emergency. Patients typically present with this side effect if you haven't gotten lab work or keep it on your radar to get lab work and check that white blood count. If you have a patient in the early stages of methimazole treatment and they're starting to complain about a sore throat and fever, these are often your first signs of agranulocytosis in these patients. Other side effects we have to look out for are a maculopapular rash, which is going to sometimes cause pruritus or itching within your patient. You can get arthralgias. You can get a cholestatic jaundice, which is going to occur because you have a blocking of the bile flow, and that causes jaundice within the patient. Uh, you also have to consider with any hyperthyroid treatment that you go too far in the other direction. So methimazole can lower your thyroid hormone levels too much, which is going to lead to a hypothyroidism. If that happens, you have to consider a dose adjustment. Your dose might be too high. You have to cut it back a bit because you're blocking the thyroid hormone production too much. We don't want to completely block all production. We want to get them to euthyroid, where they're not having symptoms of either hypo or hyper. So if you start them on a dose and now they're coming in for follow-up and they're starting to complain of hair loss or cold intolerance or weight gain, you might need to get lab work to make sure you haven't sent them into hypothyroidism. And then a very important thing is to consider pregnancy considerations. Methimazole you want to avoid completely in the first trimester of pregnancy due to risks in the baby of neonatal hypothyroidism, so blocking that thyroid production in the baby. You can cause a neonatal goiter or congenital hypothyroidism. So during that first trimester of pregnancy, PTU, which we'll talk about in a minute, is going to be our preferred medication. If the hyperthyroidism persists, though, into the second or third trimester, once they get into that second or third trimester, we'll switch them back to methimazole. So just in that first trimester is when we avoid methimazole. On to our other thionamide medication, our propylthiouracil, or PTU. It is another thionamide and works very similarly to our methimazole or MMI. And it's going to be working primarily, again, by inhibiting that enzyme thyroid peroxidase. By inhibiting that enzyme thyroid peroxidase, you're going to basically block or prevent the synthesis or production of those thyroid hormones at that iodine step. So it's also going to block the coupling again of that MIT and DIT, and if those can't couple, they then can't form T3 and T4. Another action it's doing that's a little bit different than methimazole is it's also blocking that conversion in the periphery of T4 to T3. So T3 again is our active form. So if T4 can't then get converted to T3, it's not in that active form to cause those symptoms. So that little bit of difference is it's blocking the production within the thyroid gland itself and then also acting in the periphery, and it has that dual action. Again, it's going to take about 3 to 8 weeks or so to achieve that euthyroid or normal thyroid hormone state, whether you're using propylthiouracil or methimazole. So MMI or PTU take about 3 to 8 weeks. And that's because they're not actively destroying thyroid hormone that's already stored within the body. They're just blocking that conversion of further production of thyroid hormone that can be utilized within the body. PTU is generally just going to be reserved for patients who can't tolerate methimazole due to side effects. It's not as safe of an option as our methimazole, except It is our preferred option for hyperthyroidism in that first trimester of pregnancy. So if you have a patient that is going to be trying to conceive and they don't want some other form of intervention like radioactive iodine, surgery, then you might consider putting them on PTU until they get into that second or third trimester of pregnancy where MMI can be given to them and is safe for the fetus at that point. Looking at our side effects or adverse effects, again, very similar because it is a thionamide to methimazole. You're going to see one or two key differences here, but again, you're looking for that potentially life-threatening serious side effect of agranulocytosis, that low white blood count in these patients, typically again in the first 3 months or so, and a lot of times they'll present first with like a sore throat or fever. If that's the case, it can require immediate medical attention. Like methimazole MMI, your PTU can also lead to hypothyroidism, meaning you're blocking the production too much. So you're going to want to monitor those thyroid levels and see if you need to adjust the dose if it's blocking it too much. You're going to get that maculopapular rash that causes itching. Some arthralgias might happen. You can still get that jaundice because of the impaired bile flow. The big key difference, though, is PTU is much more hepatotoxic, and there is a black box warning on it for severe liver injury or acute liver failure. So it is going to be very crucial with PTU compared to methimazole to monitor those liver functions during treatment. It can still cross the placenta and cause that congenital or fetal hypothyroidism, but it is still preferred to methimazole for managing that maternal hyperthyroidism in the first trimester of pregnancy because it's not as common as methimazole to cause those congenital abnormalities. This is just a brief picture to show why methimazole tends to be our primary thionamide we use, especially if we're treating your Graves' hyperthyroidism. And really, it's because of that rapid action and its effectiveness. It acts faster than your propylthiouracil or PTU. It has a longer duration of action, which is going to allow you to use it more in just like a convenient once daily dosing. With this, your results are going to be quickly achieved. You get that euthyroid state probably a little bit faster than your PTU. And generally, your MMI has a lower side effect incidence and profile than your PTU. Even though those side effects are very similar and a lot of them are the same, you see them less often with your methimazole, your MMI. But just keep in the back of your mind again that even though methimazole is our preferred choice for most of our patients, PTU is going to still have some significance in specific circumstances, especially again during that first trimester of pregnancy, because methimazole is more likely to cause significant teratogenic effects like that congenital hypothyroidism. So during that first trimester, or if someone is planning on getting pregnant within the next few months, put them on PTU, and then you'll switch them to MMI once they get to their second or third trimester. As with many conditions and many medications, we have to monitor our patients when we start them on a lot of medications. So what are we monitoring when we put them on a thionamide like methimazole or propylthiouracil, so our MMI or PTU? We do need to look out for some of those adverse effects. We need to look for signs of an acute illness. So that fever, that sore throat that might indicate that someone is having that agranulocytosis. We need to look for jaundice. Are they getting that cholestatic jaundice? Are they getting some sort of acute liver failure with PTU? So we got to look for that liver dysfunction, especially with PTU, because again, that has that black box warning for acute liver failure. You need to look for any new or worsening symptoms and promptly evaluate those. We need to perform that CBC with a differential at baseline, again, to look for that white blood cell count. You don't necessarily have to monitor that white blood cell count unless you get those signs of an acute illness and you're concerned for that potential side effect of agranulocytosis, that side effect of that severe drop in white blood cells. Our main thing we're looking for, though, is our thyroid. So with these, we do need to monitor our thyroid function. Initially, you're going to do a TSH, your thyroid stimulating hormone, and a free T4. So you get that for your diagnosis to begin with. And again, hyperthyroidism, you're going to have high thyroid hormone, so high free T4, which is going to cause a low TSH. You're going to be trying to get that to a euthyroid level, normal TSH, normal free T4. So you're going to be checking these at 4 to 8 weeks after starting treatment and monitoring until they get to euthyroid. Once they get to euthyroid, you can extend that to every 2 to 3 months to make sure that they're continuing to get proper management of those thyroid hormone levels. So if someone comes in and you've had them on treatment for a while, or you just started treatment and you're seeing them 8 weeks after you start treatment, and now their T4 is low and their TSH is high, you're thinking, oh, my dose is way too high. I need to adjust this a bit because now I've sent them into a hypothyroidism. So I need to lower that dose. Opposite, you see them back 4 to 8 weeks later. Their T4 is high, their TSH is low, they're still hyperthyroid. You might need to consider upping their dose a little bit. You're going to have to play around with those doses a bit until you get them into that euthyroid state, and then you can extend out how often you're checking thyroid levels to just make sure they're staying euthyroid. How long do we treat these hyperthyroid patients for? Are they on these forever? Is it just a short-term type thing? The typical duration of our therapy with these thionamide medications, your MMI, your PTU, is going to be about 12 to 24 months, so about a year or two, with your primary goal being to induce long-term remission of their hyperthyroidism. If you use a thionamide alone, the average remission rate for patients on these anti-thyroid medications is about 40 to 60%. So about half of patients that are on these medications for 1 to 2 years will go into remission in their hyperthyroidism. So that's success. Their hyperthyroidism is treated at this point. They are euthyroid, even off of the medication. It is important to note, though, that while anti-thyroid drugs can effectively control the hyperthyroidism as long as they're taken, those remission rates, or when patients remain euthyroid for a year after discontinuation, are generally under 40% after 1 to 2 years of treatment. However, they can significantly improve, or a remission for over a year after discontinuation can exceed 80% if some patients take these for 5 to 10 years. But typical duration of treatment is about 1 to 2 years. Patients that have maybe mild hyperthyroidism or a small goiter, or if they're on the thioamide therapy and their goiters start shrinking, those are going to be our patients that we're going to see more likely to achieve remission. So more likely to stay euthyroid for a year after discontinuation. If a patient discontinues their thioamide and at some point they relapse or become hyperthyroid again, you could restart treatment with a thioamide, but that's not going to be our preferred because it didn't really work that first time. So our preferred thing to do if they relapse and become hyperthyroid again is going to be looking into radioactive iodine instead of another course of antithyroid medication, because the radioactive iodine is going to provide a more definitive solution or a permanent solution for managing the hyperthyroidism in these patients. Radioactive iodine, or iodine 131, I-131. This is going to be considered another first-line option for treating hyperthyroidism, particularly in our patients, again, with Graves' disease, a toxic autonomous nodule, or multinodular goiter. So how this works is when you administer the radioactive iodine, the I-131 is going to be absorbed by the thyroid gland. Once it gets absorbed by the thyroid gland, it's going to disrupt or block the synthesis of those thyroid hormones by incorporating itself into the thyroid hormones and thyroglobulin. Once it incorporates itself into those, as a result, the thyroid follicles that take up that radioactive iodine are going to undergo a breakdown or necrosis, leading to a destruction of those overactive thyroid cells. While radioactive iodine I-131 is going to be a preferred treatment for long-term management, thioamides are often used initially to control symptoms, especially in patients who are pregnant and can't have radioactive iodine treatment, maybe have just a mild hyperthyroidism, or require rapid symptom relief prior to this more definitive treatment. So again, radioactive iodine is a first-line option. You're going to use it for more of a long-term management, more successful management compared to a thioamide. But thioamides, if someone doesn't want to undergo the radioactive treatment or wants to try something possibly a little bit safer, or they're pregnant or just mild case, they might use a thioamide instead of this radioactive iodine. So this is going to minimize the impact on surrounding tissues and is a really valuable treatment, this radioactive iodine, for many patients. With any medication or process, we have to look at adverse effects, side effects, risks of these medications. And while radioactive iodine is a very effective treatment for hyperthyroidism, you got to be aware of the side effects. The big one you have to tell people is eventual hypothyroidism. As we talked about with the mechanism of how radioactive iodine is working, it's being brought into the thyroid tissue and causing necrosis and destruction of the thyroid tissue. So these patients will get, and one of the most common outcomes is a development of hypothyroidism, which is why some patients don't want to go this route right away, because if they then have hypothyroidism, they have to treat that as well. You might get a radiation thyroiditis or an inflammation of the thyroid itself due to that exposure of the radiation. Patients sometimes can get a temporary rebound hyperthyroidism. So directly after treatment, they might have a temporary increase in thyroid levels again. So their symptoms might shortly increase right after treatment. you can get a worsening of thyroid eye disease. So if a patient has thyroid eye disease, they may experience a worsening of their symptoms in their eyes after treatment. So if someone is starting off with moderate to severe thyroid eye disease, you're going to want to avoid radioactive iodine. This isn't going to be a treatment option for those patients because it can exacerbate those symptoms. Because of the radiation exposure, there is a potential risk for developing cancer in areas. This is considered to be a low risk, but some patients might not want to take that risk. So again, that's why they might choose surgery or thionomides. And then this is going to be an absolute contraindication in pregnancy. There is a risk of fetal harm, so you have to ensure patients are not pregnant before you initiate treatment. Because of the radiation, you do also want to make sure you discuss with your patients precautions to minimize exposure to others around the treatment timeline, including close contacts with children or pets. And this might be for several days after treatment, and it might be that they have to sleep alone or in a different place if possible, to reduce the risk of exposing someone else, especially children or pets that are going to have higher side effects from those radiation risks. Another option for hyperthyroidism, although not a great option, is our iodides. These are going to include your saturated solution of potassium iodide, or SSKI, or your potassium iodide iodine, your Lugol's solution. And these have a somewhat unique mechanism of action in managing your hyperthyroidism. They work through this paradoxical suppressant effect on the thyroid. These high concentrations of iodide are going to reduce the uptake of iodine. And if you reduce that uptake, it's going to block the release of the thyroid hormone. And this is going to occur because the iodide is going to inhibit both the synthesis of the thyroid hormones as well as that coupling of your MIT and DIT, which are going to create that T3 and T4. It is important to note, though, that even though you have these suppressive effects, they are not indefinite, meaning they do not really have a long-term effectiveness. Long-term use of these or administration of these can lead to a loss of efficacy of these medications, which is really why these are not typically used as standalone by themselves therapy. If you do see these used for effectiveness sake, it's usually in like an acute setting, like a thyroid storm, or to just have a short-term suppressive effect on the patient prior to a surgery. So again, they can be used for Graves' disease as like a suppressive effect before surgery, or in like an acute situation where you're throwing the kitchen sink at someone with a thyroid storm. And another reason that you're not typically using these for long-term therapy is some of these side effects. You can get hypersensitivity reactions. Some patients might complain of salivary gland swelling, which can cause like a sore throat or mouth soreness. And then large doses may even exacerbate the hyperthyroidism for a little while, even though it's that paradoxical effect. If you have too much, you're now causing a hyperthyroidism exacerbation. So again, optimal, if you're going to use these, it's usually in conjugation with like a thionomide or radioiodine therapy. They're not typically used solo, and they're not typically used for long-term management. Now we are looking at our beta blockers. And I know I briefly mentioned them on other slides on as far as when we were looking at the images of where these medications are working. But we've talked about beta blockers before, and you know that they're beta blockers if you're looking at the medication because most of them end in that LOL. Our main ones we're using for hyperthyroidism as of right now are your atenolol, propranolol, maybe metoprolol, depending on the patient. And these are going to be critical in the management of your hyperthyroidism patients. And it's because they have this ability to rapidly alleviate or make the patient feel better as far as those thyrotoxic symptoms that they're getting, those palpitations, that heat intolerance. They're decreasing that stimulation. Um, so you do want to start a beta blocker as soon as you get the diagnosis of hyperthyroidism, even before confirming what the underlying cause is. So even before you confirm that it's Graves' disease causing it, you're going to start them on a beta blocker for rapid symptom control. They do not work to fully treat the condition. They are an adjunct. So they're working as adjunctive therapy alongside whatever anti-thyroid control you're doing, whether it be the thionamides, your radioactive iodine, those iodides that we talked about. And then you're also going to use these as part of that huge kitchen sink you're throwing at patients that are in a toxic thyroid storm. As far as how you're dosing these, one of the side effects of your beta blockers is bradycardia because they are stopping that contraction or slowing that contraction of the heart, and they're decreasing those palpitations, which is what you want, but you don't want it to get too low. So you're going to titrate the dose of these, aiming for your patients to have a heart rate between 60 to 90 beats per minute. So you want that kind of normal heart rate of 60 to 90. Just remember, we have some contraindications. You don't start these in someone that has decompensated heart failure. Yes, your beta blockers are used as part of your heart failure treatment algorithm, but remember, you don't start them in active decompensated heart failure. You use them in someone that's already being treated and they're into a better state, not decompensating, because it can exacerbate those heart failure symptoms. So contraindicated when they're decompensated. Contraindicated in anyone that has any sort of bradycardic condition. So sinus bradycardia, a heart block, sick sinus syndrome. They're not going to be used in anyone that has those because you don't want to cause that bradycardia to worsen. And then we want to try not to use them with anyone that is on these antidepressant medications of MAOIs or tricyclics. Side effects, just to review a few of them, they can cause a little nausea and vomiting. People can get some insomnia, lightheadedness, bradycardia. But again, these are going to be crucial for symptom control in most of your patients with hyperthyroidism, and they're really going to ensure a smoother management process as those other therapies take effect. Because when we talked about those thionamides, they take 3 to 8 weeks to get someone to euthyroid because they're not depleting the already created thyroid stores. So beta blocker as soon as you diagnose in order to rapidly alleviate the symptoms that the patients are getting. Just a quick little recap slide to go over the advantages, disadvantages, maybe a little comment here or there on the different treatment options for your hyperthyroidism, especially caused by Graves' disease. When you're comparing these treatment options, some key studies showed that all of these options, your thionamides, MMI-PTU, radioiodine, I-31, or surgery were effective at normalizing thyroid functions within 6 weeks of starting treatment. 95% of patients are completely satisfied with their choice and would recommend getting treatment to someone else. 84% really endorsed radioiodine, and 75% that had surgery really endorsed it. 68% or so, the studies showed endorsed thionamides because they have a higher relapse rate. About 40% of people with the thionamide use will relapse. 21% with radioiodine might relapse, and only 6% with surgery might relapse. Long-term studies have shown that your radioiodine and surgery do tend to lead to better outcomes, but the reason patients won't go that route first off is because they are going to lead to an eventual hypothyroidism, and ultimately the patient's going to have to go on treatment for that with like a levothyroxine. When we're talking about all of these medications, all these options, you're thinking in your head, okay, well, how do I figure out what do I do for my patient that I have right now? And there are some general treatment guidelines, and a lot of it is going to be based on the disease severity. For all patients, let me reiterate again, we start them on a beta blocker at diagnosis. So every patient, no matter the severity, is going to get a beta blocker as soon as you know they're hyperthyroid to help with the symptom control, the symptom management. If we look then at mild disease, this is going to be characterized by a free T4 level that's about 1 to 1.5 times the upper limit of normal. They're going to have minimal, if any, thyroid enlargement. These patients, we're going to prefer to do thionamide therapy first for that 1 to 2 year course. So that MMI is preferred. You could consider PTU based on their circumstances, but you're going to really look at methimazole for 1 to 2 years. If the patient's like, I don't want to risk that 40% relapse and I want something just definitive, they can opt for radioactive iodine without needing a thionamide pretreatment. If your patient has more moderate disease, so this is where your free T4 levels are about 1.5 to 2 times the upper limit of normal, they might have moderate thyroid enlargement. You're still, a thionamide is going to be your preferred choice, but a patient might need more long-term management. They're less likely to be successful without relapse. But you still, a lot of patients are going to want to try that for a year or two and see if they can get euthyroid in remission on your methimazole. Again, though, radioactive iodine is an option for definitive treatment. And with moderate disease, you may consider pre-treating them with your thionamide to euthyroid before you do your radioactive iodine. And then we've got our severe disease where your free T4 levels are getting to about 2 to 3 times the upper limit of normal. And this patient might have a really noticeable goiter. What you typically do for these people is you'll start them on a thionamide. So methimazole is your preferred thionamide versus PTU. You're going to start them on that thionamide therapy before you consider then what do I do now? Do I just keep them on a thionamide long term for years? Do we do surgery for the patient? Do we do radioactive iodine? And this is going to be decided based on what are their other things they've got going on. Do they have that big goiter? Do they have some sort of complication risk involved with the surgery or radioactive iodine? Do they have thyroid eye disease? Because remember, we don't want to do radioactive iodine for someone with thyroid eye disease. Are they pregnant? So that severe disease, you've got lots of options, and it is going to be really dependent on that patient and their situation. So overall, generally know that in most uncomplicated diseases, thionamides are going to be your preferred first line. If they do want a definitive treatment, the recommendation is typically your radioactive iodine. If they have a severe disease, they're probably going to need both. They're probably going to need a quick thionamide regimen to get to euthyroid, um, with a beta blocker for their symptom management until they get euthyroid with that, and then do radioactive iodine or surgery for definitive management. That is really like your general treatment guidelines. Now, in medicine, everything is not the same for every single patient. So you're going to have some special considerations you have to look at. If they've got something else going on, you need to look at that, and it may change how you treat your patient. So when you're treating hyperthyroidism, and someone has thyroid eye disease, so if you look at that picture attached to here, they've got those bulging eyes. So part of that is that thyroid eye disease. Their eyes can be dry. Um, so with this, if it's mild, we can usually start with a thionamide therapy. But if their thyroid eye disease is more moderate to severe disease, surgery is often where you're going to have to go for a definitive management to make sure that you get them managed so their eye disease doesn't worsen. And then remember, radioactive iodine can worsen the eye condition, so you are not going to use radioactive iodine with any patient with thyroid eye disease. In patients with large goiters, or maybe they have a nodule that's suspicious for something else, like a cancer, surgery is typically your preferred approach, especially if they have some sort of like hyperparathyroidism going on at the same time. You're just going to go surgery, definitively manage it, definitively get your answers, and get them under control. And then always consider pregnancy. So if a woman is hyperthyroid before becoming pregnant, it's best if you can to try and stabilize her condition before she gets pregnant. So if she's planning to get pregnant, try and get it under control before she even gets pregnant. Um, but life happens. We can't control these things all the time. Some people get pregnant and aren't trying to get pregnant. So you have to consider that. And if they are pregnant, no radioactive iodine. Absolutely contraindicated. If it's not under control, you're just diagnosing them, they're pregnant. First trimester preferred is going to be your PTU, your propylthiouracil. Once they get to their second or third trimester, a lot of times you'll see people switch them to methimazole. You can keep them on PTU, but methimazole tends to be a safer medication. This is another picture form of putting it all together for my people that like flowcharts and pictures, algorithms, those sort of thing of all the slides we just talked about. So brief synopsis, uh, medical treatment wise, medicine wise, every person that you diagnose with hyperthyroidism, you're going to put them on a beta blocker. Usually beta blocker, it says calcium channel blocker on here, but calcium channel blocker is going to be your option if someone has a contraindication to your beta blockers. So beta blocker for symptom management. Once they're euthyroid and you're not worried about those symptoms anymore, you can take them off of the beta blocker, wean them down off of it. Remember, you don't abruptly stop beta blockers. You're going to try and titrate that heart rate on the beta blocker to about 60 to 90. And then you're going to look at your other treatment options. Remember, our first line, typically preferred, especially for mild disease, to control that hyperthyroidism is going to be your thionamides. So your methimazole, your propylthiouracil, so MMI, PTU. This is going to block that production of your thyroid hormones. You're blocking that coupling of MIT, DIT. You're blocking that TPO, that peroxidase, that's going to block that production. PTU is also going to be blocking that peripheral conversion of T4 to T3. So T3, the active form, you're blocking that conversion. Agranulocytosis, that big drop in white blood cells that can make someone more likely to get an infection, is that big caution with all of these. You also, with PTU, have that black box warning for liver failure. You have those iodides as an option, but remember, they're short term, they're not as effective. You might use them as like an adjunct. If someone wants something that is more definitive, because the remission rates of those thionamides can be like 50% in some cases after 1 to 2 years of treatment, then you talk about radioactive iodine versus surgery. Radioactive iodine, remember, don't use it in thyroid eye disease, don't use it in pregnancy. Both surgery and radioactive iodine are going to make most patients hypothyroid, and they'll need to have treatment for that with like a levothyroxine. Next few slides are going to be talking about a thyrotoxic crisis or thyroid storm. As far as for this course, so for pharm, I am not going to be testing you on this. This is more FYI for your information, knowing that these people are very sick. It is a life-threatening condition with a high mortality rate. You'll learn a bit more about it in your emergency medicine course and in CAM. And really the treatment you'll see in the next few slides is to stabilize them how you can, and you're kind of throwing every avenue at them. Throw the kitchen sink of medications at them to get them stabilized. Hooray, we're on to hypothyroidism, so our low thyroid levels. So remember, as far as our lab work goes, we've got our low thyroid levels that we see on our blood work, and those low thyroid levels are going to be going through that feedback mechanism and increasing our TSH, because TSH is trying to create or stimulate that production of thyroid hormone. So at diagnosis, you've got increased TSH, low thyroid levels. When we're considering hypothyroidism, we're also looking at the range of symptoms and signs that help identify this condition. Our common symptoms for this guy are going to be our dry skin, we get cold intolerance, we can notice some weight gain and constipation, because with hyper, everything was stimulated, everything was moving faster. With hypo, it's not being stimulated, everything's moving slower. We're getting dry, we're cold, we've got decreased metabolism leading to weight gain. Our gut isn't moving as fast, so we get constipation. We can get weak and lethargic. Anyone that comes in with depressive symptoms, you're typically going to run a thyroid panel on them also, because depression is a high and common symptom of hypothyroidism. You can get infertility issues due to the fluctuations in those hormones, muscle cramps. On exam, they might have a coarse, dry skin and hair. You might notice a periorbital puffiness and swelling around the eyes. They might have bradycardia because you're not stimulating the heart as much, a slow speech pattern, and then you can occasionally notice some neurologic symptoms that are going to be important to recognize so you can treat it fast. Similar to our treatment outcomes, what we want to happen when we're treating these patients with our hyperthyroidism, we want that same thing to happen here. We want our goal of therapy to be achieving a resolution of those symptoms. All of those symptoms we just talked about, we want those to be taken care of. We want to get rid of those signs that we saw on physical exam, the dryness, the puffiness, those sort of things, the bradycardia. It's also going to be essential to restore those thyroid levels and get them to a more euthyroid state. But also, similar to our hyperthyroidism, you can overtreat and then with hypo, if you overtreat and you give them too much, you can now make them hyperthyroid. You really need to be cautious with over treatment, especially in your elderly patients, because they might be more sensitive to these thyroid hormone fluctuations. And your drug of choice for hypothyroidism is going to be your levothyroxine. Its brand name is Synthroid. And that's going to be our main guy that we address hypothyroidism with. Levothyroxine is going to be our main drug of choice as far as our treatment for hypothyroidism. It has several advantages over some of the other things that we're going to be talking about. It's chemically stable, it has a long half-life, it's relatively cheap and inexpensive, and it has a pretty uniform potency to it. Mechanism of action, levothyroxine is really T4. So we're giving more T4 in order to get that converted to the active form T3. So it's converting T4 to T3, maintaining nearly normal levels of both hormones in the body. Normally, it is generally well tolerated. But we do need to monitor for some side effects. The main thing that we see is overtreatment. So if you overtreat with your levothyroxine, you're going to see symptoms of hyperthyroidism. So all of those stimulatory effects of the thyroid hormones, giving you the nervousness, anxiety, tremors, heat intolerance. You're increasing that metabolism, causing increased appetite, but also weight loss, and then stimulating the heart, causing arrhythmias or palpitations. So you need to adjust the dosages carefully to prevent overtreatment. And we'll see on the next couple of slides, we have a pretty good idea of dosing for your patients, and it's usually weight-based or condition-based. So we just have to watch out for giving too much of it. So if you gave too much of it and someone comes in on your follow-up and how's your levothyroxine treating you, and they start saying, well, I'm losing some weight, feeling my heart all jittery, we'll get some lab work and make sure that you're not causing them to be hyperthyroided now. So once we start treating our patients for their hypothyroidism with our levothyroxine, again, levothyroxine is our drug of choice for hypothyroidism, we have to look at our correct dosing and we have to monitor them to make sure that they are where they're supposed to be. Our monitoring and dosing of our levothyroxine we're gonna be looking at it to make sure that it's compensating for that deficit of thyroid hormone that we have. If we have a patient that's elderly, any cardiac risks, those sort of things, we do need to start at a lower dose. If you look at the previous slide, there is a weight-based dosing that you'll do for just an average patient. But then if you look, if they're elderly or have cardiac risks, there is a specific dose that you'll start at, and then you'll slowly monitor them and add on to the dosing as you need to, or adjust the dosing as you need to over time. The correct dose is going to be achieved when their symptoms of hypothyroidism are reversed without any signs of toxicity or thyroid excess. So like we said, the side effects of levothyroxine are excessive thyroid hormones, so you're essentially making them hyperthyroid. So you get all of those symptoms of heat intolerance, weight loss, jitteriness, insomnia, palpitations. So we're trying to avoid that. We're going to be monitoring our TSH for treatment with levothyroxine, our hypothyroidism treatment. So we're going to check our TSH every 4 to 8 weeks after starting therapy. If you get that lab back and it shows that your TSH is elevated, that means the body is still sensing it doesn't have enough thyroid hormone, and that's why it's trying to stimulate production still. So if that's the case, we have to increase our dose of levothyroxine, and then you'll check again in about 4 to 6 weeks. Whereas if our TSH is decreased or less than normal, that might mean that we are overdosing, that they have too much of that levothyroxine. We got to back the dose off a bit. So we're really trying to get our TSH, our thyroid hormone, all within that euthyroid type level, as well as get rid of their symptoms. Once you do establish a maintenance dose, then you can back off on the testing. So instead of every 4 to 8 weeks, you'll start checking it every 6 months to a year. You do want to just give your patients a little bit of education about taking their levothyroxine. And part of that is understanding that food as well as other medications can alter or impair the absorption of levothyroxine. So the best thing for your patient to do is take it first thing in the morning with a little water and separate it from antacids, iron, calcium supplements by at least 4 hours. Um, Symptom improvement, as far as those hypothyroid type symptoms, may take a few weeks. So just let them know, be patient. We got to replete those stores. We got to get things back to that normal level, and that can take a little bit of time. Also, it's going to be lifelong treatment. Our hyperthyroid meds with the thionamides, we said it's about a 1 to 2 year treatment duration. With these, it's lifelong. We have to continuously replete those stores for the rest of their life. It is a bit of a controversy out there. You're going to get different trains of thought on taking the same brand of levothyroxine. Uh, some studies had shown that different brands' bioequivalences were off and people weren't getting the same effectiveness. But then newer studies are showing that that isn't quite the case, and switching among various of generic manufacturers hasn't shown to be too much of a problem. So you're going to get different trains of thought there on whether or not you should take the same brand every time. In addition to our preferred medicine, our levothyroxine, which is T4, there are some synthetic thyroid hormones that you can use, but they are used less often. I really just want you to know these exist. They're not by any means preferred. Liothyronine, your T3, it does work faster than levothyroxine, but it's got a big disadvantage of having much higher risks of cardiac side effects, especially if you have patients that already have some sort of heart disease. It's also very expensive, has a shorter half-life, so you have to take it more often. And it's a bit harder to monitor with our standard lab work that we typically get for these patients. There's also a medicine called Liatrix, which has this conversion of T4, T3 of a 4-to-1 combo. The combination does have this stable potency involved with it, but again, it's very costly, it's very expensive, and we haven't seen much of a clear advantage of doing this compared to just using the cheap, good old levothyroxine. Then we also have a natural thyroid hormone, like our Armour thyroid or Nature thyroid, which both contain T3 and T4 that are derived from animal sources instead of synthetically made. However, they can be antigenic because they are derived from those animal sources. Just to review, if you don't know what antigenic means, it means that it possesses the characteristics or properties that could make someone have an immune response. This immune response could involve producing antibodies, activating immune cells, and causing an immunity against the medication. So with this, a lot of these have unpredictable formulations. They're harder to dose. They're harder to have long-term advantage of them. So they're not really commonly used because they can be quite variable. And there's also been consistently in the past 5 to 10 years national shortages. So if you do have someone that is on this, there is a conversion you can use, but you won't need to know that for this test. Now, a quick review of our glucocorticoids, our corticosteroids, our steroids, any of those terms we somewhat use interchangeably when we're talking about medications. Remember, these medications, a lot of them end in "-sone" or "-lone", like our hydrocortisone, betamethasone, cortisone, prednisolone. So that's how you remember which medications are our steroids or our glucocorticoids. Just like when we were just talking about our thyroid production of hormones, these also work through that negative feedback loop, but this involves the hypothalamus, the anterior pituitary, and the adrenal cortex. So when somebody experiences stress in their body, physiological stress in their body, or some sort of other stimulus, the hypothalamus releases CRH, or corticotropin releasing hormone, which then prompts the pituitary to release ACTH, adrenocorticotropin hormone, which then stimulates the adrenal cortex to produce cortisol, and then that's going to regulate various responses throughout the body physiologically. And then we have that negative feedback loop that when we have enough cortisol, it sends a signal back up to the hypothalamus and pituitary to stop it from creating any further corticotropin releasing hormone or ACTH. And then what do these glucocorticoids do physiologically within the body versus pharmacologically in the body? So pharmacologically, like if we're giving someone prednisone, it's going to act as a powerful anti-inflammatory and immunosuppressive. So it's blocking that inflammation, it's blocking that immune system from acting too haywire. So that's why we use it when we have a big inflammatory response or in a lot of these autoimmune conditions. We're trying to suppress that immune system from causing all these issues. They're going to impact metabolism as well as electrolytes by suppressing protein synthesis, mobilizing fat deposits throughout the body, raising glucose levels, which is why we have to use some caution in our diabetics and giving them steroids, inhibiting calcium absorption in the intestines, which is why it can cause our osteoporosis. Um, and then the key reason we're really using these, again, is really an anti-inflammatory action or some sort of immunosuppressive action. Just a review of some of the adverse effects that you should remember with our steroids or glucocorticoids, including our osteoporosis, again, because of that impaired calcium absorption in the intestine, increased risk of infections because of the immunosuppressive actions, hyperglycemia. We want to use caution in our diabetics because steroids can raise glucose levels, as well as the most dangerous one that we've talked about is adrenal suppression. This adrenal suppression occurs because glucocorticoids shut down the body's own production of cortisol. If therapy is stopped suddenly, the body might not produce enough cortisol by itself, which can lead to an adrenal insufficiency. That adrenal insufficiency can be life-threatening. Patients are likely going to need a stress dose of glucocorticoids to make sure that they don't go into an adrenal insufficiency during any times of trauma, surgery, infection, any big stressor on the body. They may even need some sort of stress dose for things like that after stopping therapy until the adrenal function recovers, which can take a while. Some key drug interactions you want to remember for our glucocorticoids is because, again, they can cause some electrolyte issues, especially with potassium loss. You have to use caution with anything else that either has a potential adverse effect due to low potassium or also causes potassium loss. So if you remember from our cardiology section last quarter, our thiazides in our loop can cause hypokalemia, so we don't want to cause further loss of that potassium. And then if you remember with our digoxin, if it's combined with someone who is hypokalemic, you can cause fatal dysrhythmias like torsades. So you want to use caution interacting those two together. You also want to use caution with NSAIDs because steroids can cause GI ulcerations and bleeding. So NSAIDs also cause GI ulcerations and bleeding. So taking them both at the same time potentiates your risk even further. And then caution with any hypoglycemic agents or insulin. They might not be as effective because these steroids can increase sugars, so hyperglycemia. So it might be counterbalancing and counteracting what you're trying to treat. So you might have to increase or alter your dosages of your insulin or other diabetic agents. And then because of the immunosuppressive nature, you want to use caution or postpone any live vaccines. Because your immune system is suppressed, you could actually increase the risk of spreading the virus you're trying to vaccinate against.